It is an honor to welcome to the stage Dr. Lui Forni to discuss bicarbonate therapy for AKI. Yes or no? Oh yeah, let's hear it for Dr. Forni.
Select audience. That's what I like. So, yeah, someone laughed. Rabi's the only person who's laughed. We have to supply a photo, right? So I took one of the old ones out of the cupboard. So, bicarbonate. Yeah, interesting drug, right? So I thought, is there anything new I can learn about bicarbonate? So I started looking through Wikipedia and the other things. And apparently, an American senator, it would be turn of last century, proposed bicarbonate as a treatment for Spanish flu. Imagine that. Who would have thought that 100 years later, another American politician would suggest bleach for COVID? Anyway, I'm allowed to say that given the fact I come from that small island that's been segregated off from the rest of the world. So we're going to talk about bicarbonate, right? So these are my potential conflicts of interest, none of which I really interfere with this talk. Remember, bicarbonate is cheap as chips. But there are other potential conflicts of interest, right? I've been interested in bicarbonate for a very, very long time, since the last millennium, before Daniela was born, probably. So this was a paper on bicarbonate therapy in intracellular acidosis. This was a paper that never, ever gets quoted, right? This is the first paper on the treatment of bicarbonate-based hemofiltration. All of you use that, right? But little did you know that this idiot and some of his friends were the first ones to do it. We made the solutions up ourselves, and these are other. So these all came in like 1970, 1978, when I looked like that, when I was a young boy. My memory is clearly playing tricks on me because I don't remember being in the US Air Force, but, perhaps I was. Anyway, so why has Rabi asked me to talk about this? Right? Why are we talking about acute kidney injury and whether bicarbonate is useful therapy? Well, it really stems from this study, the BICAR ICU study from a French group of Samir Jabba, where they did a multi-label multi-center open-label study on metabolic acidosis and treatment with bicarbonate. So standard therapy that a lot of us say we use, and yet there was very little evidence for it. So Samir did a study, and this was the evidence before they started the study, that bicarbonate has been sparsely evaluated. Reviews from experts have recommended against its use, because you may remember, particularly the anesthetic community, had this big thing about paradoxical intracellular acidosis, which I can talk to you about in the break, really, because it just gets my blood pressure up. Right? But more than half of critical care physicians or nephrologists will consider bicarbonate infusion for a patient with severe metabolic acidemia. So even though we might not have any evidence, it was still regarded as a standard therapy by many. This was their consult diagram. You can see they had 942 patients eligible, 400 were randomly assigned. Now that's pretty good, I think, because we kind of forget that statistic, but a lot of times you see, well, there were so many eligible, like Start AKI, for example, 20-odd thousand, far less actually randomized. So Samir randomized about half of the patients. What did it show? Well, the optimistic may say there was a nod towards an improvement with bicarbonate, but probably not. But one of the predetermined subgroups was acute kidney injury, as defined by the AKI criteria. And you can see that, rather surprisingly, there seemed to be a mortality benefit associated with the introduction of bicarbonate to these patients. So metabolic acidosis in patients with acute kidney injury, there seemed to be an improvement. And in brief, this was a summary of the BICARB ICU trial by our French colleagues, suggesting that you had to treat 6 patients to effectively save 1 life. So that was quite interesting. More interesting, in fact, was the fact that they showed a dramatic reduction in the need for renal replacement therapy. So that's one thing that particularly interested me. So, of course, a paper like that then begets more papers, right? So this is effectiveness of bicarb on mortality in septic patients with metabolic acidosis. So looking at a septic cohort in the MIMIC database. People deserve a medal for using that because at times it's impenetrable. But anyway, they looked at the MIMIC database and they used propensity matching, and they matched a bicarbonate group against a non-bicarbonate group. They had 500 pairs after systolic PSM, and you can see that again they showed an improvement in patients with metabolic acidemia and acute kidney injury. And there seemed to be a signal again. And that's the overall results that they showed. So their conclusion was that we need further large randomized controlled trials are needed to confirm these results. How many times have we read that in the intensive care literature? This is a scoping and systematic review, similar from Ronaldo's group. And they were talking about, given the lack of data on bicarbonate, there's a need for further studies. This was a pilot open-label study by Kianoush, if he's in the audience, looking at bicarbonate in a low chloride solution. This was just a pilot study, again showed a benefit in terms of outcomes with bicarbonate in patients with acute kidney injury. Another systematic review, this used different databases and showed, again, there was an improvement. This is a really interesting paper, I think, because this is what happens in the real world. Again, it's from Australia, which, are blessed with having a pragmatism that the rest of the world envy, I think. Decompensated metabolic acidosis in the ED department. How often is actually bicarbonate used and what outcomes do they look for? So they assessed the eligible patients, nearly 1 million, right? And they got a very small group, of which 58 had bicarbonate, and no bicarbonate was given to 258. This is the most impressive thing, I think. So about 1 in 6 of this group got bicarbonate, right? But the administered dose was completely stereotypical and reflected the size of the bottle rather than how bad the patient was or how bad the acidosis was. So what that means is, if you go into an Australian ED, or indeed any ED in the world, if someone says, "Oh, they'll give you bicarbonate," they'll give you 1 bottle. That's it, right? They'll give you 1 bottle and say, "Oh yeah, they've had bicarbonate." No one seems to follow up and see what effect it's had on the pH. So the Frank Zappa fans in you might like to know that Frank Zappa said one size doesn't fit all. I don't know if he was the first person to say that, but it's quite cool. But apparently, for bicarbonate therapy, one size does seem to fit all. So this has triggered other debates in the literature. This was a three-pronged debate we had in intensive care medicine. There was a pro group, which was the French, negative group, which was John and colleagues from Pittsburgh, and the kind of UK sit-on-the-fence group. And so what the French pointed out was their bicarb ICU didn't show an effect on the primary outcome of mortality, but it did show an improvement in the French group, in kidney injury. The Americans had a different view. They had quite severe criticisms of bicarb ICU. It was unblinded. Personally, I think if you're a critical care physician and you can't work out if you've given bicarb or not, you probably need to go back to the books. But anyway, it was unblinded. And the need for renal replacement therapy in this cohort was left to clinical discretion. Right, okay, that's reasonable. And it wasn't powered for the effect on acute kidney injury. And that's the key, right? It wasn't powered for effect there. And, John made these very sensible remarks. The key to correcting acidemia is to identify and treat the cause. That's for sure, right? But, and that's exactly the same when we apply renal replacement therapy, right? We're applying renal replacement therapy, but quite often the cause of the sepsis or whatever also needs to be addressed. So use of bicarbonate infusions or even renal replacement therapy are adjunct therapies to buy time. Yeah, for sure. And then, although carefully selected benefits, but may benefit, the average patient will not. Well, that's up to debate, isn't it, really? And then there's a SID thing, don't get me started. So we'll move on to what did I say, or what did me and my colleagues say. We said that we didn't really think there were any robust recommendations at present. The basic tenet is that the underlying cause of the acidosis should be corrected. And we suggested a PICO-type approach to this, where the patient population would be patients with metabolic acidosis and acute kidney injury, unsurprisingly. But then the treatment arm was where the bicarbonate was treated to achieve a target pH. And then the fairly standard comparisons and outcome. So our key really was a particular interest in bicarbonate should be focused on patients with acute kidney injury. And until those questions are answered, Janus, who you may remember is the god of doors, will keep the doors open for bicarbonate therapy for now. So where are we, right? Where are we with this? Can I give you an answer? Well, unsurprisingly, here's bicarb ICU2. So this is a second French study looking at patients with acute kidney injury and severe metabolic acidosis. And this is their outline of their study. Trial design, multiple center randomized trial study. Again, not blinded, and it's the largest trial ever conducted on bicarbonate and metabolic acidemia. They're looking at 600. Bear that number in mind, right? Largest trial, 600. So, and this is their, oh, sorry, I went a bit. Anyway, that's their trial protocol. They've just about finished recruiting. And so if Ravi invites me back next year, I might be able to give you a bicarb study with a bit more meat. But in the meantime, I'm running a trial with my pal Nick Selby in the UK, Mosaic study, looking at sodium bicarbonate in acute kidney injury and critical care. We've now just up to 500 patients in a similar cohort. Our study is powered for mortality, an 80% power, so we should have near 2,000 patients. So the 600 will be dwarfed by ours. So hopefully we'll have some answers in the not too distant future. Otherwise, at the moment, we're on the wait and seesaw. And with that, I'd like to thank you for your attention, and I guess we'll take questions at the end, or it's up to the chairwoman.
We might have time for one question, if anyone. I guess I'll take a question. How about the good old-fashioned bicarb deficit? Is it just pediatricians who calculate this and actually administer the right dose?
Yeah, you could do that, but really the main studies were aiming at correcting the pH, right? And so that's an easier thing to do, right? For us adults, we're just simple souls. So we just look at pH. But you could look at the bicarb deficit. And in fact, we could do that secondary analysis to see how much of that we actually achieve, because that data's big.
Yeah, let's do it.
Yeah. I'll put you on that paper, all right?
Okay, what an honor. Okay. All right, well, thank you, Dr. Forni.